Hello everyone and welcome back to another episode of the IDRiM podcast. Today's episode is a continuation of Tuesday's episode with Kadia, and we were examining her paper regarding the 2018 outbreak of cholera in southwestern Cameroon. Last episode we left off talking about the accuracy of data and its importance. And in today's episode, we are going to carry on and talk very much about how morale can affect data collection. So, when I was reading this, and we've kind of touched upon it already, you've talked a lot about burnout. You've talked about staff demoralization. How much outbreak response depends upon the morale and the trust of the staff and the community, other than just the infrastructure of getting out there, stopping the spread, providing, the medication to stop further onward spreads, and or you know what I mean. It's like, how much is the staff important and the trust in the community important?
These are very important aspects in public health emergency management, and the manpower is the backbone of the response. That is it. You can have all the infrastructure you want. You can even build the trust with the community, but if you don't have the manpower to back all that work, it's going to go in vain. So some resources has to be diverted to cater for the staff, to cater for to make sure that they are in a conducive environment to be able to deliver what they know best how to do. Now, talking about the community, the trust of the community, it is very important because I will share with you something that happened in the far north, where I once worked. There you have more of the Boko Haram terror. And an international and did a need assessment, and the result of that need assessment was that they had poor sanitary systems. And so the solution that the organization saw was to build a borehole of water. They built a borehole of water and a latrine, and the defecation was done in free air. So they said, no, these people need toilets and they need a borehole, and they built it. That was a wonderful project. But at the end, when they looked at the use of it, none of the community member ever used those things that those people built. And that was because they did not build that trust with the community. They did not understand the people with whom they were about to work. They didn't understand them. First of all, the women prefer to go and fetch water at a distant place because they use that time to discuss about their husbands. So it's a time for self-care. They walk at a long distance. But the people implementing the project didn't know that. They just felt, oh, these people need water. We've given them water. They should be grateful. And so you see, there's that misplaced way of delivering, of implementing projects. And more in recent times, you see projects recommend that you must have a representative of the community. You must have religious, leaders involved. You must have host community. You must have those people that you are going to help. They must share, they must understand what you are doing. And Professor Andrew often said that, he often said that you have to build on what is there. You build on what is there. You don't come with something new and think that that is the new, revolution or whatever. and it's something that we see every day. People have amazing ideas, but they forget to, contextualize it so that it helps the people that need the help. Yes.
Yeah, and it's a bit like it's almost like indigenous knowledge. You've got to understand, what they require as well, and what their way of thinking through these issues. Because the likelihood is that those who come in to help these communities who have had these, diseases, who have had these disasters, before, it's not going to be the first time you've ever experienced this type of issue. So they'll have their ways of dealing, with these outbreaks or these um, disasters. But we have a tendency, and I know that Western responses has always been like this: is we go in and we think we do this, we do that, and that's going to fix everything. And it's like, yeah, that's not going to fix everything. It's like there's an old parable that I was taught, of why you don't do that. And the way is that you could give a community a cow. And the fact is that if you give a community a cow, if they're hungry, they're just going to eat it. You
Mm-hmm.
mean you've not, then because you've not explained and make them understand that actually that cow can provide milk that you can sell on to buy food. They just think
Yeah.
it's a resource, or you do that, with a sheep, or whatever it is, in different contexts. And that's the issue, I think, with sometimes with humanitarianism, with certain groups who think that they can go in and fix the issue, and that's it. And what we don't do is we don't spend that time, because sadly there's so few humanitarian response teams nowadays to actually go into these affected communities to understand their problems, their needs, and how we can work with those to try and fix the issue and address the issue so that they don't need the external help and aid longer term. And I think that is exactly what's happened in Haiti. We went in, we provided them food, we provided them shelter. Great. But what after 6 months, after a year? They're going to be back in that same situation as they were after the
Yeah.
disaster. And that is something that it's 2026. We've spent 50, 60, 70 years of research on this, and we're still making the same mistakes. And in the end, it's going to cost so much money in aid to
Yeah.
try and fix this, because I'm just thinking, people criticize. I know in the UK, aid spending is very criticized nowadays, and
Mm.
a lot of Western countries don't want to spend so much money on aid, and because it's now so small, it's getting worse, and we need to find ways to address these issues so we don't have, because we're going to have a lot less to spend with, and we're going to end up with situations getting worse, and we've not learned from these situations because of it. I don't know if you want to chip in on anything I've said.
Yeah, yeah. I mean, what it's so true. The long term, how will it look like in the long term? We never think about that. How will it look like in the because the aid that is hard as the Indian work complement to complement what they're bringing in, and it looks so vertical, so unidirectional, and at the end of the day, everybody you know wants to get out of a certain situation, but the person helping you should be able to create that space for you to grow. Why not all this? Why not use part of it for the part of it for the aid and part of it for capacity building. Build a structure that I think people will all this now you hear a lot about colonialism, even external aid more. I know of organizations that don't even want external aid because there's already this this subconscious this connotation that the aid comes with strings attached. No matter how innocent it is, they're like, "No, I might not know what the strings are now, but they are coming with strings attached." And that's because in the long run, you ask yourself, 50, 60 years we'll be receiving aid. Why do we receive more aid now than we received even 60 years before? I think, why are things getting better? So it's just mind-boggling.
Yeah, and it's like what you said about this, aid and strings attached, and it's a bit like what happened in Morocco after the earthquake. So Morocco refused aid from France because of the colonial past, and they were worried that there was going to be a string attached to that aid. And the fact that countries are now refusing aid because of these perceived strings, it's frustrating. It's sad that it's get that, but it's also understandable why this happens. I mean, we know that aid was used as a soft power by certain countries during the Cold War. It's blatantly obvious now that that's what it was used for, and it shouldn't be that way. But it's the way that the system has kind of built itself up, and it's so annoying, so disheartening, and I problem is now is that it's so ingrained. It's going to take a long time to break that old system down and put in a system that actually is more sustainable.
I look at it, it's like even at the micro level, those things happen, even at the micro level. And analyzing it from even a micro level, you will see that when you receive those kind of donations and aid, and you look at it in the long term, you see that it doesn't you lose more in the long term than you've gained in the short term. In the short term, it looks like, oh, you are the winner and all of that. But the person, as you say, is a soft power, it's a mechanism of control. It has so much more to it, but at face value, it looks like you're being helped. And a lot of countries are getting a wake-up call on and are taking measures. Let's go through the short-term pain, avoid the long-term will come if we take this route. They are exploring options. They're exploring other options that, and there are other options that can. They are slower. But if we engage in those in terms of a community with unity, I think that a lot can be achieved. But the fast way is to take the aid and then you keep, getting into the rabbit hole on and on and on like that.
As you'll have noticed, we have been having some technical issues regarding the audio with Cadia, which kept dropping out. The remainder of this episode was now recorded using just audio only to save bandwidth and to make sure that the audio doesn't drop. We can only apologise this, but it's technology and these sort of things do happen. So in your research paper, what interview or field site stayed with you most personally after the research? Because what we find with a lot of researchers is sometimes there is always a moment or a thing that really stands out, and it also, I sometimes think it drives the paper when you write it. So, for you, what was it?
Thank you for the question. As I was saying, it's really uh, a very good question because it makes me to go back to things I overlooked and to really see how they marked me at the time. And one of it was the focal person for disease surveillance, the regional focal person who said something that, stood out for me. He approached He's going down to the field to get data. Usually that's not something he does. He has subordinates who do that, but with the emergency he had to support the team. And going down to the field, he told me, I started understanding why this particular district always send in their data late, always had issues. We sanctioned them, we complained about them, but right now I know that moving forward, I'm going to be patient with them and I'll always ask how I can help. So I really felt that if we had more staff, more supervisory staff that approached the field level work in that sense, we'll see more genuine results because a lot of other districts will send in falsified data because of the pressure. But this particular district, they will try to do what they have to do, even though they'll get criticism, they'll get all they'll be called all sorts of names. But now he understands that their challenges are so many. Another thing that really stood out for me during this research was when I began seeing the results and realizing that the health information system at the time of that outbreak was not capable of informing decisions. It was utilizing resources. The system utilized resources. The system drained staff because they had to enter the same data into three different platforms. Even so, that data was not used to inform any decision that was made at that time. So two things stood out for me. The first thing was that, so what what did the decision making team base themselves to make the decisions that they did at that time? Because the surveillance system would indicate, would profile hotspots where the disease is. So if they didn't utilize that data and they invested so much resource, so where did they get the information to inform their decision? The second thing that stood out for me was uh, really the impact of having a system that is just there to report, and so much is invested in it. There's no follow up. There's no evaluation of how effective the system is, right up to the time when it's tested during an outbreak. So for me, it was very stunning as findings from that study. But currently, a lot of work has been done on the district health information system, and I believe that some of these loopholes have been closed. Yeah, that's what I can say for that question.
In fact, one thing that stood out for me there, what you said, was that some of the districts were falsifying, data, and that horrifies me as a researcher because, especially with health data, it's so important because how do we know how bad the situation is? Because, you know, in terms of, say, malaria, or in terms of anything, if it's an infectious disease, having accurate numbers can help contact trace it, and work out
Yeah,
how, and if you're getting random numbers, how do you then start the process of contact tracing or trying to find out where, who patient zero is in that situation?
Yeah, that's really a brilliant observation because you know the compounding effect of such small carelessness, responding to pressure rather than, doing your job, you're responding to external pressure can have really dramatic effects during outbreaks because the minutes count. Cholera spreads so fast and it's so the mortality rate is so high that um, you can't really afford to do things like that. But those things happen. They happen. Yeah.
Mm. Yeah, and actually it come across, in your paper about all this because you quoted a participant saying the system showed diseases like, Ebola and the bubonic plague incorrectly. I mean, so what does that tell us about, data governance, in this situation? Because we are all relying on data now, and how on, how on earth do we get a situation where we're getting cases? I mean, Ebola, as we're talking, there's a huge outbreak of, Ebola in the DRC. You know, what does that tell us? Because that's going to be wasted resources on trying to find who actually has it, even though it's not there.
Yeah. It's really important that uh, before we experience pandemics or outbreaks or public health emergencies, our health information system should be tested for us to understand what is needed for it to function optimally so that in cases of emergency, we don't function in survival mode. And really, that's what happens in low income countries. We tend to be very reactive, and at the end of the day, what we produce is not really helpful in terms of generating data, that can inform decision that can help contain a disease or even eradicate a disease. So at this point, we need to understand our own context and dynamics. Yes, there are things that we may not want to speak about. For instance, demotivated staff are quite mentioned in my paper. When staff are demotivated, there's a certain tendency to create parallel networks that can, generate funds for them to sustain their livelihoods. And sometimes these parallel networks have detrimental effect on the health of the population. When those small things are compounded, they have detrimental effect. For instance, if people are asked to go for supervision in remote areas and they decide not to go for those supervision, they decide to stay in their offices and do remote data collection instead of going to the field. It's difficult for a facility to rate themselves poorly. But if you're on the field, you see that, okay, this is their reality. But because a facility might not want to come across as poor performing, they will tell you and give you figures that are not real. And because you yourself have not made that effort to go on the field, you base yourself on that data, and then it's a ripple effect. So we need to understand our context, our challenges, so that we reduce our tendency of, being reactive, reacting to things, generating data that, is basically it cannot inform. It cannot inform anybody, it cannot help. But so much resources gone, as you say.
So here's a question that extends beyond your paper related to this. Is this practice still happening? Is there cases still where diseases are wrongly being inputted into the system that is not true? Because I know of it actually got really ridiculed in the media. I can't remember if it was this year or last year, where UK Health Security Agency reported a case of the bubonic plague, and then when it wasn't, when it turned out to be errors data, they, they were literally, all the papers were making jokes about it, which obviously is not a jokeable thing. So does this still happen in Cameroon?
Um, since 2021, after my paper, when I returned back to Cameroon and still worked in the field of data management, there was a lot of work being done at the level of uh, the district health information system, lots of trainings and decentralization of the system to the facility levels, because the district health information software was only available at the health district level. But now the health facilities have data managers who have been trained specifically to address issues from the district health information system, which I think is a very great advancement and is commendable. And the issues that we can foresee that will come up are issues of sustainability, because in order to work with these systems, we need resources, we need staff who are consistent. If you train 5 data managers today, and at some point their salaries, they feel that their salaries can no longer sustain their lifestyle, there's a huge brain drain, lots of health staff moving abroad, moving to for greener pastures. And when they leave with the knowledge. There are no resources allocated to retrain other staff. So if a staff leave abruptly and another staff has not been trained, that gap needs to be filled. And usually the interim is done by somebody who doesn't really master the system. So we can observe things like that. We can observe things, reporting errors, data is not cleaned and all of that. So those are some kind of systemic challenges that we foresee that the system will face. So it's not something, the erroneous data is not something that we foresee that within the next 10 years this will completely be eradicated, because a lot of other problems which will lead to the production of erroneous data have not been addressed.
Yeah, and in the UK, the situation in a weird way is actually not much better. You talk about brain drain. So, some of the statistics for the United Kingdom is really quite bad, actually. I mean, so for example, 5,500 doctors trained in the UK left last year. Left the country for usually for better money. Because doctors are not the best paid profession in the UK, and this brain drain issue seems to be an issue that affects a lot of countries now, and it raises more questions, and then you're under more your healthcare's under more strain trying to recruit doctors and nurses who can fill those positions. So I'd imagine also data collection and stuff like that also in the UK is becoming increasingly under strain as well. Thank you for watching and listening on our second part with Kadia Susanna. regarding the cholera outbreak in Cameroon in 2018, and obviously other related healthcare questions, both in Cameroon and more globally, especially around data. Next week, we have 2 more episodes with Kadia, where we go into these questions much more. And for example, in the next episode, we actually start talking about duplication of data and why we need paper as well as digital data in times for health crises. We hope to see you next time.